I didn't want to sort of take up any additional time. We do have a pretty packed agenda for the remainder of the day. So I want to give respect to our presenters and those who have come out to join and share with us today their full allotted time. So that's why I'm going to ensure that we just keep plugging along. So our next part of the day will include a panel conversation that's facilitated again by our own PACHA member, Laura Platero. I did fail to mention earlier that Chairman Nicholas Lewis, you see him listed on our agenda, was unable to make it today, but I do think we got a full wealth and breadth of information from Maria, Laura, and Rick. So appreciate that conversation. But moving ahead, I really want to turn our next panel addressing HIV in American Indian and Alaskan Native communities, turn it over to Laura for her expert facilitation. Laura, the floor is yours.
Thank you so much, Madam Chair. So again, just so grateful for us to be here today to actually talk about
Laura,
HIV.
I'm sorry, really quick, before you start, I need to make an adjustment to what I shared for the members around the table. You will need to push the button on your mic to turn it on for you to speak, and you can push it to turn it off. I was mistaken. If you see a piece of black tape on it, it's on. Don't touch it. If your mic does not have a piece of black tape on it, you will need to push it, and you'll see the green light when you speak, and when you push it again, they'll turn off. So just wanted to make that adjustment so everyone can be heard and people can hear you online. Thank you. Apologies. Please continue.
Okay, great. Thank you. So just really grateful to PACHA for having its meeting here again and for having most of this day focused on American and Alaska Native HIV work. So again, this is wonderful to be here. We also were able to do 2 site visits yesterday, one to the Phoenix Indian Medical Center, and thank you, Heather, for the tour there, and Native Health. I see many of the staff here today. Thank you for being here. We really appreciate your presence and for the hospitality and the site visit yesterday. So coming back to the focus to today, I know we're going to show a short video. Is that right? Like a few minute video before, just to kick us off?
We have the video that.
Oh, I was told we were going to show just one snippet. Yeah, 30 seconds.
Let's talk about HIV prevention. Those of us at high risk for getting HIV through unprotected sex or injecting drugs need to know about PrEP. PrEP is a safe and highly effective medication that can help prevent HIV. When taken consistently, PrEP can reduce a person's risk of getting HIV through sex by 99% and by more than 70% for people who use injection drugs. If you're at risk for HIV, it's time to make prevention a priority. Talk to your healthcare provider to learn whether PrEP is right for you.
Thank you. So that's just an example of some of the work taking place in Indian country in terms of messaging. This one is on PrEP, and we'll have some other ones to show you later today, hopefully. So I want to just jump right into our panelists and introduce them. And we're going to start off here with Heather. So I'm going to read a bio on each panelist. Each one will have about 15 minutes or so to give their presentation. So the first is Heather Huntleman, and she is a captain in the U.S. Public Health Service. She first worked in the Indian Health Service during a pharmacy rotation in Cherokee, North Carolina. After graduating from the University of Florida, she completed her residency at the Phoenix Indian Medical Center, and she also established the first full-time position with the Indian Health Service for HIV pharmacy and just completed her 19th year of service. So thank you for that. So Heather, I'll turn it over to you to start us off as our first panelist.
Thank you for having the meeting here and as well for inviting me to speak. I am non-native and I was chosen to represent. It's green. I don't want to speak. I appreciate being selected to be here. I am non-native, but I am also the senior member of the HIV Centers of Excellence. It was established in 1996 at the Phoenix Indian Medical Center. And I have been there for 19 years now. I And so my position was originally, I was there as a pharmacy resident doing a longitudinal rotation. And then the year afterwards, I started providing pharmacy services. I was the acting director from 2009 to 2016. And right now I'm the clinical HIV pharmacist. We provide HIV, PrEP, and Hep C services. We are primarily funded through Minority AIDS Initiative. We would not be able to do the things that we can do without that money and the support from headquarters and the IHS program. It's an incredible partnership because I know that at any point I can go and talk to them, be real with them, be honest with them, and then we can come up with solutions together on how to make that work and to try to help us get the things that we need. We also have some Ryan White funding. I know that across the nation, American Indians, Alaska Natives utilize Ryan White funding quite a bit, but for us, it's probably 25% of our patients. There's an additional barrier with Ryan White paperwork and all of those things. And part of the reason that American Indians are incentivized to do it in other places is that they don't have any in-health services that can provide direct HIV care. Therefore, they have to go through Ryan White to be able to have the case manager, to have the access to the AIDS drug assistance program and all of those things. Where for us, it's a complement to what we're doing. They can get full HIV services, including behavioral health, case management, pharmacy services at Phoenix Indian Medical Center. And Ryan White is a complement to that can help with housing and transportation and food boxes and some of the supportive health things that they need. Our patients choose to come to us. We have almost 400 American Indians, Alaska Natives that are active and living with HIV. And we have about 115 patients that are taking PrEP. And I was excited the last time I looked at the data right before this that we've had at least 300 American Indian Alaska Natives that have had at least 1 month of PrEP. And so that's a huge milestone for us that we got to that point. And our patients, you know, they choose to come to us, and not only because they have resources. Thankfully, Medicaid has been expanded to childless adults in the state of Arizona, and it's fully funded. And so they could go to any clinic in the city, and they choose to come to us. And when they get upset with us and go away, they end up coming back. And part of the question yesterday was like, why does that happen? Why do they come back? And one of our case managers helped me formulate an answer for that. Part of it is the culture. IHS is interwoven into the culture of American Indians, Alaska Natives. We're on Res Dogs. We're in podcasts. We're in the contemporary art at the Heard Museum. So Indian Health Services is part of the culture and the way that things are in that community, and it's what they trust, even though they get upset with us and we don't always meet expectations. There are other things that we do, like representation. Our team has multiple representatives from the American Indian Alaska Native community, as well as the LGBTQ plus community. So they are coming and seeing their people help take care of them. Indian Health Services, the whole point, at some point, I should not be able to have my job because it should be provided by American Indian Alaska Native pharmacists instead of me. And so because I've been here for 19 years, I've had this privilege. But the newest pharmacist we hired is American Indian Alaska Native. And I know that when I do leave this position, it will be another person because I've trained 50 pharmacists to be able to do what I can do so that I will be the last person that is non-native providing these services. So that representation is really important. And then just understanding what it means to be on the res and that culture. So when I'm talking to my patients, I'm like, okay, well, you know, when you go to the res and that 3-day visit turns into 2 weeks and now you don't have enough medications. You know, I talk to them about strategies, about taking meds with them, always calling us. I've shipped to businesses, hotels, worked with local IHS to make sure that my patients stay on their medications. You're not going to get that somewhere else. And I have the privilege because we can provide the medications. I can do early fills. I don't have to get an override. I don't have to do all of those things. And so the things that we can do there and understanding the nomadic way that they live and how things are done and that they may go back for a season or for a ceremony and the support we give them for that. Also, the support we give for their native traditions and for seeing a medicine man or anything like that.
we have those conversations, and, if it's a one-time thing, I'm not worried about drug interactions, but if it's something you're going to be on consistently, let's check an extra viral load, let's check an extra, kidney and liver panel and make sure that you're doing well. So we're making sure that we're working with that. And I assume that those things are happening. They don't have to tell me. And so we talk about those things, and we just ask to have that partnership. Trauma-informed care, we provide that for everyone. The historical trauma, the generational trauma. I know when my patients come in, they have first-hand experience with suicide, domestic violence, substance misuse, missing persons. And this isn't like they know someone, multiple someones, and have had to deal with this for a long period of time. And it is part of who they are. And I know that when they come in the door, and they don't have to tell me, and they don't have to tell anyone on our staff. And that's a great place to start the conversation, because those are things that are difficult to share. And we can pick up on little things that they say, and we understand where that's coming from. And so that is a huge part of Indian Health Services, and why they do come back to us is because they know that we are not going to judge them. I know that on the res, they may not have running water. They may have food insecurities. They're going to have multi-generational family households. When they talk about auntie, that's not going to be an auntie, maybe in another system, or biologically an auntie, but that is the auntie. So understanding that part of their life and their culture and their experience just puts us so much farther ahead, so that we can provide the care that they need and put them at the center of that. So that's why our patients come to us. And we actually see 2/3 of the American Indians, Alaska Natives living in the state of Arizona at Phoenix Indian Medical Center. We are the center of choice, and they come to us, and we are very proud of that. We have an amazing team. We have accomplished a lot. I did want to mention one thing about U equals U, because it talked about what that has done for stigma. U equals U was huge. When I started talking to it about with all of our patients that have been there for years, people that I thought understood and knew the relief. We had people that started dating after 30 years. We had people that called their mom from the room, bawling, saying, we don't have to worry anymore. They were still worried about toothbrushes and razor blades and an accidental infection. And I'm like, you can have sex with people, and you're not going to transmit. So that relief was huge. And I take every opportunity to talk about U equals U. I do it in every single presentation, regardless of what the topic is, because people still don't know. I talk about it at parties and invites and those sorts of things, because it's just not out there. And reducing stigma is what is going to help us along. Treatment as prevention. All of those things are so important. The fact that you can have PrEP, and it's 1 pill once a day, and reduces HIV risk by 99%. That 60 seconds of data is not in the general population. So having that in a way that PSAs have worked in the past, getting that ingrained into the community would help us get ahead. So some of our successes that we've had, we finally have been able to gain some of our staff members back. As you know, COVID really hit American Indians, Alaska Natives very, very hard. And I lost a lot of patients that had made it through losing partners and friends, and lived through the 80s and the 90s. And a significant number of people were wiped out by COVID. It was devastating for all of us. We had an excellent immunization rate. We immunized 85% of our patients living with HIV for COVID, all of those efforts. And we were able to do it with incredibly low staffing. So those are, some of our successes. We've expanded PrEP through pharmacy students and junior co-steps, and anyone that I can get to come to work with me, I will hand you a list, and you will look it up, and you will talk to these people, and we have to get the word out there. So there is so much work to do, but we have tried to leverage what help we do have. This past year, we were unable to add another pharmacist position. So instead, we used that money to bring in pharmacy residents from other service units. So we had some from South Dakota. We had another one from White River. They came to us for a month, and I taught them how to do pharmacist-led PrEP. In exchange, they made sure that our data was up to date, that our patients were in care, and that our patients had been contacted. And so that's been a great partnership and really worked well. At Phoenix Indian Medical Center, they just started a PHN-driven STI clinic where they can have some walk-in services. Our patients were just going to urgent care to try to get STI testing. There was no other real way for them to access care. We have a user population of 100,000, but we have an incredibly small number of people that are actually impaneled. So there is no other way to get care. They are adding a nurse practitioner that will specialize in STIs, and that's going to really help our population. Universal testing. So, HIV testing has been standard for a long time. In the beginning, when the expansion of testing, I think it was in 2013, we initiated it right away. It happened in our primary care. And not only were we going to test once in a lifetime, it's a reminder in our electronic health record to test a minimum of once every 5 years. Obviously more often than that based on risk. But we have been doing this work for a long time and we're early adopters. The place we can't put it in as easily is urgent care and ER, and we are working diligently to do that. Also because we don't just want to implement HIV. It pains us to do that, knowing that there's syphilis, hepatitis C, and all of those things. So we have to make sure the mechanism is in place so that we don't miss those things. We gained a new expertise in MPOX over the past year. Our patients were affected by that. We had great partners with Maricopa County. We were the first clinic to provide TPOXX to a person in the state of Arizona. And I felt like we had a great response to that and were able to support our patients through immunization and access to medications. And we outreach to those patients by anyone that had ever been given PrEP, by anyone that was living with HIV. We made sure that all that messaging went out and that everyone knew that those vaccines were available. Our challenges, communications with patients, finding something that meets FedRAMP standards that's going to allow us to communicate by text. All communications have to become part of the electronic health record. Any group that we use has to have certain approval and meet FedRAMP standards, and we have not found a way to easily do that. And we are dealing with a population that is young, and they do not want a voicemail, and they are not going to have their voicemail set up. And to send them a secure email adds another level of security, and now they've got another password to do, and it's just not the way they communicate. So that is definitely a challenge for us. And so, encouraging companies that are working with other organizations that have been successful and having and helping them through that FedRAMP process so that we can have somebody that meets the standards. And Indian Health Services, so I am at a federal facility. We are, but there are other places that are tribal facilities, and they're completely run. They have, by the tribe, they have been 638, which means their dollars go directly to them. So they have a lot more freedom to be able to do as they see fit with their money, where we're still under federal guidance. And so at Phoenix Indian Medical Center, we have a little more limitations than maybe at some tribal clinics where they can do more things and utilize more programs. And so there's definitely a difference there as part of Indian Health Services. Substance misuse, it is definitely our number one comorbidity that limits adherence and whether or not our patients can come to us. So, our entire facility has a user population of 100,000, and we have 2 substance abuse counselors on site. We do have partnerships with Native Connections and other community providers. We are adding a specialist to Phoenix Indian Medical Center. But, with substance misuse and housing and our access to those services, it can be really difficult. And even when we partner with Native Connections, it's not easy for our patients to get from us to them and all of those things. So having the time and the staff to be able to help with those warm handoffs and to be able to provide that work. Our number of patients is out of proportion with our staff. So our population is 400 persons living with HIV, and usually a case manager would have a 50, possibly 75, depending on the acuity of the patients. So we have 4 case managers for 400 patients, plus we have 115 PrEP. Plus, at the end of last year, we'd cured 253 American Indians, Alaskan Natives that were formerly living with hepatitis C. So this is all the work that we're doing, and it's a limitation. Our facility is 6 times smaller than it needs to be. So literally no space is one of our major issues, and getting that facility replaced would definitely help all of our programs advance. With our current numbers, we probably would need 10 case managers, 8 for the ones we have and 2 to grow on, and to help with PrEP. So knowing that and the limitations that we have, this morning I logged in and did work before I came here because it's not going to get done. It has to be done. So that's the reality is that even though we know what may need to happen, we literally do not have time to do it. And then I think the last part is that communication, that building, that going to tribal council meetings and working with ITCA and all of these partners. We used to have a position that was dedicated to that, and that has been, utilized in other ways at our facility just because of the understaffing that we have overall. But being unable to partner and physically being at meetings and talking about these things reduces patients' access to PrEP. We've had some new cases, and they were previously on PrEP, and they went back to the reservation and came back and didn't start as quickly as they should have and acquired HIV within 3 to 6 months of being back into Phoenix. Although that is very difficult for us, the worst is when the new patient that came in had been getting STI testing every 3 months and didn't know they could get PrEP from us, had asked for PrEP and didn't receive it. The facility they asked at didn't know that PrEP was $60 for a generic. All these limitations and barriers were put into place, and that person acquired HIV by not knowing where to go or how to get to us. And if they had just walked in the door, everything would have been taken care of. So those are the key cases that we worry the most about, is not having that information out there. And it's not just a one-time, right? So we know what the data is. You go to the ER and you talk to the staff about testing for PrEP or testing for HIV, referring people for PrEP. It happens and then it trails off. So not only do you have to do the work, you have to do the work quarterly, multiple times a year. You have to have that champion. You have to have that advocate. And in attending this meeting, today I have put in 4 additional hours of work on my time because I can't do that. I can't take time to attend a meeting and do what I need to do for our patients. And so that's where we're at. We are at critical mass. We know the work that needs to be done, but we don't have the time to do that community relationship building and that advocating and making sure that the word is out there and that they know that we're here. So we need activated, motivated partners that can help bring patients in, PSA messaging, public relations, people that are going to do that. And not only does it need to happen, but that work needs to happen over and over and over again so that we're not missing those people. So that's where we're at in the work we do. I have one of the best jobs in Indian Health Services. With all of that, I would change nothing as far as my job. I am blessed to be where I am at. I work with the best team on the entire campus. Everyone cares. Everyone is there working. Everyone is missing breaks and putting off lunch and doing all of the work. And so it is remarkable to work with my colleagues, but then also our patients. Our patients are incredible people. They have all of these things where there's a 75-year-old grandmother taking care of 5 grandchildren. You have other people that are caregivers for family members and all of these difficult things, plus all the trauma that is happening directly to them. And still 90% of our patients are virally suppressed. So if we can do it, anyone can do it. But I do worry at this point that we are at a point that those numbers may decrease. They did decrease during COVID. We went down to 87% last year where we were at 89. I'm assuming we're going to be back in the 90 range, but I don't know how long we're going to be able to maintain that with the level of staffing that we have. And so that is kind of a synopsis of what's going on at Phoenix Indian Medical Center.
Thank you, Heather, and thank you for taking the time to be here and sharing your challenges and obviously what's working, because you have patients coming back and getting the care that they need. So again, we're just so grateful you're here today. So I'm going to move on to the next panelist. The next panelist is Jessica Leston. She's an MPH and she's Shishimian. She's our clinical programs director at the Northwest Portland Area Indian Health Board, where she focuses on systems and policy change. She began her health career working at the Alaska Native Tribal Health Consortium in 2004. She honors the Alutiiq cultural value, we are responsible for each other and ourselves. So, Jessica, the floor is yours.
Okay. Hi, everyone. Can I share my screen, or is it going to be pulled up on the end over there? Okay, wonderful. Thank you. Amasani, Jessica Diwayu. Hi, my name is Jessica. Thank you so much for inviting me to talk a bit today. I use she, her pronouns. My mother's side of the family are mixed white settlers to Turtle Island, and my father's side of the family are both mixed white settlers and Tsimshian from Southeast Alaska, originally from British Columbia. And I am going to talk a little bit today about applying the syndemic strategy that Rick was talking about earlier to a rising public health threat and rising public health threats that we are seeing every day as we're going out and visiting tribes and clinics and talking to community about what is really going on. So next slide. Rick already shared this with you, so I'm not going to go over it again, but if you didn't get to capture it the first time, you can use the QR code to pull up the Indigenous strategy. Next slide. And then just reiteration, or I'm not sure 100% if Rick was able to touch on these main messages throughout the strategy, but you know, as we developed a strategy to walk alongside the national strategies for HIV/AIDS, for hepatitis C, viral hepatitis, and sexually transmitted infections, we also wanted to ensure that we were pushing forward in a good way ideas from Indian country, because we have a lot of them that are very good. And, you know, the whole idea of holistic and integrative health that is being talked a lot about right now, you know, is just an Indigenous way of depicting health and wellness. So these main messages include sovereignty, cultural responsiveness, partnerships, awareness and stigma, clinical resources and services, and data systems. And I actually think Heather touched on each one of these main messages with everything that she went over. I don't know if that was purposeful or just, you know, shows that we were in tune with, you know, the community and who we're trying to talk to in this strategy. But thinking about the time that I had to spend with you all today, albeit virtually, thank you so much for giving me the option. I had some internal conversations with myself. They were internal, not out loud to my partner, but about, you know, what the most important thing to touch on right now, like in this moment. And I was reviewing PACHA. Again, I've been working, you know, with Rick and others for a long time with PACHA, but since PACHA, you know, in its mission, you know, seeks to promote HIV and AIDS awareness, research, policies, programs, including considering comorbidities as needed to promote effective HIV diagnosis and treatment, prevention, and quality services. I really wanted to take the time to talk about one of the most important public health threats running across Indian country, and so disproportionately impacting American Indian and Alaska Native people right now. And that is syphilis. So I hope that's okay. I hope Rick and Laura don't get mad at me. But there are numerous ties. Next slide. So the CDC came out with this syndemic infographic sheet, and it talked about, the reported cases of sexually transmitted infections having increased dramatically in recent years. And that holistic, whole of society and whole of community and person approach is really what's needed, including addressing, social and economic barriers. All of these things need to be taken into consideration when we're talking about improving health related to this syndemic. So the syndemic of HIV/AIDS, of STIs, of hepatitis, of substance use disorder, specifically of opioid use disorder, so in mental health and housing. So all of these coming into play when we're talking about syndemics. There is a clear association with substance use and the increase in syphilis. There are also priority populations, LGBTQ and two-spirit, adolescents, pregnant people, and this is from the CDC, racial and ethnic minority populations, but very specifically regarding syphilis, it's American Indian and Alaska Native people, Black African American people, and Pacific Islander and Native Hawaiians. There's a huge morbidity associated with all aspects of the syndemic, and specifically increasingly high rates of congenital syphilis in American Indian and Alaska Native people. Next slide. So, just drawing the connection a little bit more, I'm, sort of giving myself permission to talk about syphilis. STIs do increase the chance of getting HIV. They also increase the chance of transmitting HIV to others. And 6% of sexually acquired HIV infections are attributed to chlamydia, gonorrhea, and syphilis. And this costs a lot of money in addition to, health and wellness, in addition to harming health and wellness of the individual and community. Next slide. So like I said, there's a clear link between opioids and other substances and STI and outbreaks of disease. Young adults who used an illicit drug in the past year were 3 times more likely to get an STI. Hepatitis, 4 in 10 acute hepatitis B cases were transmitted from sexual transmission, which is particularly stabbing since hepatitis B is preventable with a vaccine series that could be started and completed at any time, including during STI care visits. Next slide. So getting into the syphilis and why I really think it's so important. These are the primary and secondary syphilis rates of reported cases by race and ethnicity from 2017 to 2021. And, there has been a drastic increase in syphilis, specifically, like I said, in American Indian and Alaska Native people, being the highest, having the highest case rate, Black and African American people, Native Hawaiian and Pacific Islanders, and there's really a gap between those races and the other races and ethnicities down below. Next slide. If you look at congenital syphilis reported by state, you'll see these are the top 15 states with the largest number, the biggest rates in the state. And Arizona and New Mexico, Texas, Oklahoma, South Dakota, California, Montana, all of these states have a high American Indian and Alaska Native population. And in some of these states, I would say that the driver for these drastically increased rates are actually the American Indian and Alaska Native population in these states. Next slide, please. So this slide is important because, and I'm sorry, I know I'm talking to people who know all of this, but just trying to draw the connections. So syphilis is obviously, you're going to see this more in males across the board. But the female rate, specifically in American Indian and Alaska Native people, is much higher than the female rate in other racial and Hispanic ethnicities. And this is important because as the female rate goes up, specifically in people of childbearing age, then you're also going to start to see the congenital syphilis cases go up. Next slide. And that is what we're seeing across the United States. You'll see as primary and secondary syphilis rates have moved up, and that's the black line, so too have congenital syphilis cases. Congenital syphilis used to be a sentinel public health event, like an indication that there was something drastically wrong in the healthcare system. And in American Indian and Alaska Native people, there was an 800% increase just in the past year. It really is embarrassing to the U.S. public health system that this is where we are with congenital syphilis, and no one's talking about it. And it's not being addressed. It's definitely not being addressed like monkeypox was addressed. And, this at the end of the day is an issue of, congenital syphilis and stillborn and babies dying. It's a issue of women's health and prenatal care access. And it's also a women's rights issue that they cannot be getting the care that they need in the sexual health realm. Next slide. So, and this is what we see for congenital syphilis from 2017 to 2021. And you'll see the problem that I have with congenital syphilis in American Indian and Alaska Native communities. This problem is the incredibly disparate rates of congenital syphilis in American Indian and Alaska Native people compared with everybody else. And a big reason for this, a big reason for this is the state of the Indian Health Service and the Indian health system itself, not because of their ability to function, but as Laura mentioned, their ability to fund the functioning. When you have a system that's funded at 40% of need, how do you expect that system to be doing the best care possible, the best care demanded from treaty responsibility, from American Indian and Alaska Native people signing their land away in agreement that then they would have certain services provided to them by the U.S. government: education, housing, and healthcare, among others. So this is a big problem that there aren't enough people addressing. Next slide, please. Okay, I just got a text that I have 2 minutes to go. So I don't see how that's possible. I'm just really excited about syphilis. Next slide. So at the end of the day, regarding congenital syphilis, there's no timely prenatal care and no timely syphilis testing and no adequate maternal treatment despite receipt of timely syphilis diagnosis. Next slide. All of that in the contents of a national penicillin shortage. where, the only treatment recommended for pregnant people who are infected or exposed to syphilis isn't easily accessible and might be completely out at some facilities, which makes matters even worse. Next slide. So read this as you will on your own time, but basically what I did was to address syphilis, I actually used the ending the HIV epidemic pillars and showed how we can use the pillars and borrow from the information and the brain trust that has gone into these very thoughtful initiatives and apply them the same way to syphilis and expand on them and to make them even stronger in more of a sexual health context. Next slide. Next slide. You know about this. You can just go to my end slide. I do want to leave with, I think, probably the most important way that we can, we need to be conceptualizing syphilis right now for everyone, including American Indian and Alaska Native people, because this case is not only within American Indian and Alaska Native people. So there is a person, Tiffany, who's 17 years old, and she presented to the ED in late October of 2022, reporting UTI symptoms. And this is a real case. She was positive for urinary tract infection. She was also positive for pregnancy. So they treated the urinary tract infection and had prenatal labs drawn and sent. And then she was referred to the prenatal clinic at this facility. The prenatal labs that came back included an RPR of 1 to 128, TPPA positive, and a positive chlamydia screen. All of the other labs were normal. And multiple phone calls and a PHN visit later, Tiffany finally presented to the clinic in early December 2022. So that's 2 months that have gone by where she wasn't treated positive with syphilis. Laura, I'm finishing this. So she had a rash, but she reported no longer being with her partner and declines to name her partner. At the early December visit, she was treated with penicillin for secondary syphilis because of the rash and azithromycin for chlamydia. Prenatal care and ultrasounds were again arranged. She didn't make those the first time. And the day of treatment, her titer for syphilis comes back at 1 to 64. Then in late January, so almost 2 months later, Tiffany returns for her ultrasound and second prenatal visit. Her results for her RPR were back at 1 to 128, and she was positive with chlamydia again. In March, after extensive outreach and missed visits, the PHN, bless them, located Tiffany at a site associated with methamphetamine use. She had reunited with her partner, Marcus, who was never treated in the first place. The same day, Tiffany and Marcus did receive field treatment with penicillin and were screened for everything else. Follow-up is arranged for prenatal care and syphilis staging for Marcus. And despite extensive outreach efforts, Tiffany was next seen in early April in labor and delivery. She was 36 weeks and 5 days. She had elevated blood pressure and apparent intoxication that were confirmed with methamphetamine. She progressed rapidly in labor and delivered a 5-pound, 14-ounce baby with ABCARs 7 and 6. Tiffany's baby had an RPR of 1 to 16. Tiffany was a 1 to 16 RPR. The baby was a 1 to 32. And the clinic cited no obvious findings with congenital syphilis. but the baby had some respiratory issues and was transferred to an outside NICU. They received a full evaluation and treatment with penicillin for 10 days for possible congenital syphilis. Tiffany and the baby were subsequently lost to follow-up. The family reported that she had left the area in search for a sober living home in another state. But like, this is so often the story of congenital for women who are giving birth to babies with congenital syphilis. It's oftentimes linked to drug use, with women not wanting to come in for fear of their babies being taken away from them, or in some communities, them being put in prison for the duration of their pregnancy to, protect the baby. So this is a very complicated situation, and complicated similarly to a lot of hepatitis cases, or, some HIV cases, probably, a little bit longer ago when we weren't doing as good a job with screening and treatment. But this is the public health threat right now, is syphilis, and we need to collectively address this for what it is, even though it's sexual, and it doesn't come with a lot of funding like a lot of other infectious diseases. This is the issue for American Indian and Alaska Native people right now, especially in certain states. So thank you for letting me talk about syphilis over time. Laura, I apologize.
Thank you, Jessica. We're running out of time. Thank you. Okay, next we're going to move on to Savannah Jean. So Savannah Jean is a proud member of the Diné Nation, and Ms. Jean is the Program Director of the Community Health Education and Resiliency Program at the Albuquerque Area Indian Health Board. She received a Master of Science in Community Health Education from the University of New Mexico. She has over 10 years of experience in the field of youth engagement in tribal communities and HIV prevention education. So Savannah, the floor is yours.
Thank you, and thank you for the invitation to present during the PACHA meeting. What a really momentous occasion for my relatives. I say it, not that deal it that nasha, although be deal doesn't the national although other show. Good afternoon, everyone. As mentioned, my name is Savannah Jean. I come from Burnt Corn Valley, Arizona, but I've been living and working in the Albuquerque area for the past 20 years. Albuquerque, New Mexico is the indigenous homelands of the Tiwa and Keres people, and we're very grateful to be here on their lands and do this work. The Albuquerque Area Indian Health Board serves the 27 tribes, nations, and pueblos of the Albuquerque area IHS, to the Ute tribes in southern Colorado, the Pueblo and Navajo, remote Navajo communities here in New Mexico, and one tribe in Texas, Isleta del Sur Pueblo. So in addition to the tribes that we serve here locally, I am a co-creator and administrator of the National Native HIV Network. The National Native HIV Network was founded through quite a bit of foundational work since 2015. There was a recognition that there was a need for a coordinated effort of individuals working within indigenous communities around HIV and hepatitis C prevention. And so we began laying the groundwork, doing some formative participatory work during some major events that happen around HIV, within the HIV field, such as the Circle of Harmony HIV/AIDS Wellness Conference, as well as the United States Conference on HIV and AIDS. And so we were fortunate to receive funding through the Minority HIV/AIDS Fund, through Rick's office, the National HIV/HCV program with IHS in 2019. And we were able to formalize the National Native HIV Network. Our mission reads as follows. The National Native HIV Network is an Indigenous-led initiative that mobilizes American Indian, Alaska Native, and Native Hawaiian communities affected by HIV through peer-to-peer and programmatic support, training, and capacity building assistance. Our comprehensive approach is rooted in our cultural values, teaching, and affection for our communities. And this really points to this aspect of leading with our cultural values around this community building or kinship in the way that we treat one another, in the way that we relate with one another. And for the last several years, the Nation has served as a place for that community building and being able to really hear the issues that are happening within tribal communities, directly from people who are doing this work in their communities. And so we have regional representatives from all 12 IHS areas, as well as from our Native Hawaiian relatives as well. We continue to recruit for regional representatives in some areas, and are looking for individuals who are doing this work within their tribal communities, and are looking forward to being able to ensure that we have diverse representation that is also representative of all of our different populations within our communities. And so through the funding from the Minority HIV/AIDS Fund, we've been able to have this enhance our membership with the regional representatives. We've hosted bi-monthly meetings and to be able to hear about the challenges within our communities and also help provide resources to those individuals. And those individuals are also serving as the access point to their communities that they work within. We've also hosted several webinars over the last few years since the pandemic started. And we've been the lead in promoting the National Native HIV/AIDS Awareness Day, in creating the themes over the last few years and also the social media content for those events as well. But more recently, in the last year, we have been working with IHS and also New York State on a peer worker certification program. New York State created this program for individuals with lived experience within HIV. And so their program targets individuals who are living with HIV and providing them with the skills needed to be able to help their peers gain access to prevention and also treatment as well. And so we've been working with the state to tailor that training to tribal communities and also make it relevant to what that means to be a peer support worker within tribal communities. And so that is one project that we've been working on, and we're actually going to start recruitment for the pilot of that. So rather than adapting it based on our own knowledge, we want to be able to have individuals participate in the program as it is now and be able to provide us feedback on what changes need to happen to make it more relevant for their communities, to ensure that this is going to be a program that works well and is implementable within their communities. And so that's the New York State Peer Worker Certification Program that we'll be launching recruitment for here in the next month or so. So stay tuned for information on that through our social media platforms and also through our newsletter and other avenues that we have available. We're really excited about this, and I know Rick is really excited about this, as this helps to build the capacity within tribal communities to ensure that we can be that bridge. I heard earlier presenter talking about how, your capacity is limited as far as being able to engage the community because you're already stretched so thin, providing the clinical care that is needed. And so, the National Native HIV Network really wants to serve as that bridge between building that community engagement, building awareness on what is available within Indian Health Service and also other tribally run facilities as well. And so one of our goals is we're actually right now doing a strategic planning session with our regional representatives this week. And we're able to talk about, what are some of those things we want to see within the next 3 to 5 years. One, of course, is elevating the visibility of the National Native HIV Network. I know there are some people who may have not heard of the National Native HIV Network at this point. And so that's, part of what we want to see is being able to elevate that and expand that as well. We want to build culturally responsive investment for change. So really looking at trainings and building a resource library for people doing this work within tribal communities and ensuring that we can know about some of those best practices that are being done at Phoenix Medical Center or within small communities like Tsahoto Medical Center in Winter Rock or Fort Defiance, Arizona. Or in Chinle. And so, those are all things that we are looking toward, also looking at, how do we continue to build strategic partnerships for sustainability of our of the National Native HIV Network, and then build diverse but also multi-generational representation. We really feel that's an important piece that we bring is focusing on our kinship, our relationships with one another, and how those voices from our young people all the way to our elders is super important in this work and why we do this work as well. But with that, we need to also acknowledge what are those things that could be blocking us from moving toward those goals. And, we really think about how Native communities continue to be, since our numbers are so small, they're statistically insignificant. We are not a priority population, and there's this perspective that HIV prevention and STI prevention within Native communities is going to be a more reactive downstream public health approaches rather than being more upstream and being proactive in our fight against HIV and STIs. And so, we really want to see more just visibility of AIA in communities and also our Native Hawaiian relatives as well. And then being able to have meaningful engagement of our community members so that we can continue to tackle the pervasive HIV stigma that is present. And, be able to incorporate our Indigenous values and our Indigenous practices because, a lot of times our practices are not in line with the evidence-based practices that are available to us within the field of HIV prevention. And, we often have to just adapt those evidence-based interventions, but we want to see the creation of those approaches from our communities, by our communities. And then I think, people within the field of HIV, this is just something that is really common for us where we're working on 6 or 7 small grants. We have pots of money of $50,000, $75,000 that run 1 or 2 years. And so, we also want to acknowledge that we have limited capacity for people working in the field of HIV. And how do we think together as a group to strategize and ensure that we can overcome that block. And so, there are a lot of exciting things happening, and we've been very intentional about the development and really building the foundation of the National Native HIV Network, ensuring that we're not rushing through the process, ensuring that we can get buy-in for the National Native HIV Network, because, when it comes down to it, those relationships that we build are super important to the way that we do this work. And they're going to be something that is able to sustain our work, because, you know, we love our communities, we love our people, and we want to ensure that our people have access to the very best care and have access to being able to ensure that they can maintain their overall wellness. And that is, you know, what brings us to this work. We've just had this conversation about how it takes a very special person to do this work within the field of HIV. And so I thank you all for your time, and I'll leave a link to the National Native HIV Network website. And again, we're really grateful for the funding and support we receive through the Minority HIV/AIDS Fund, through the Indian Health Service HIV/HCV program. Thank you.
Thank you, Savannah, for your presentation. We're going to go on to the next panelist, so we have some time for Q&A. So our last panelist is Rydell Curley, and since 2016, he has been employed with the Chinle Comprehensive Health Care Facility in Chinle, Arizona, under the Indian Health Service as an HIV health technician in a rural setting. He has been charged with providing case management duties to a Native American patient population living with HIV and AIDS within the central portion of the Navajo land. Mr. Curley is a member of the Navajo Nation and from the beautiful mountains of Wheatfields, Arizona. And we realize we have a connection to the Navajo AIDS Network from many years ago. And so it's thank you for being here.
Yat she ya Rydell Curley in she. Senachin in sheto my deshkish ni epashichin. Hopajnaje tashe dog ashe tashanale. No rage in le holie aden isin nashato. Good afternoon. My name is Rydell Curley, and I come from a small community called Chinle in the northern portion of Arizona. I'm a member of the Navajo Nation, and I'd like to first thank you all for giving me the time to come here and to speak and to advocate on behalf of the patients that I serve. I work at a place called the Chinle Comprehensive Healthcare Facility, which is an Indian Health Service medical center that serves about 40,000 people within the central portion of the Navajo Nation. My job title is an HIV health technician, and I work within the public health nursing department. I've been there since 2016. And have been able to do a lot of work in advocating for people who live with HIV. Majority of my work entails corresponding between patient and provider. Sometimes I feel as though my work might be very minimal in terms of what a provider would offer in terms of medical stance. What I do is most times I provide appointment notifications, encourage routine provider appointments, medical lab work, medication adherence. But most of all, I sit with the patient and I get to know them on a very personal basis, a basis that sometimes the provider doesn't have. We come from a very rural portion of the Navajo Nation, where culture, sensitivity, cultural awareness is very huge. Just like the young ladies had spoken before me, it takes a very strong, very respectful person to understand, to set aside biases, and to see the patient for who they really are. In our community, we have a large portion of addiction, a lot of methamphetamine use, ethanol use, cannabis use, with high rates of poverty that exceed the national level. oftentimes this population is overlooked and not very much brought to the table in terms of understanding them. Since my induction into this capacity with Chin Lee, we've been able to create a multidisciplinary team which consists of 5 members. We have an infectious disease provider, Dr. Leslie Stewart, 1 nurse practitioner, Jacqueline Seelig, a pharmacist, Sunny Park, a psychiatrist, and also myself. When time permits from my job, I'm able to go out into the field and to help in terms of helping with HIV prevention and also HIV screening. Right now, within our case management load, I oversee 24 patients who are all male, who seek complete comprehensive care at our facility. They come to our facility seeking lab work, medication, see their primary care provider. Within our service unit, aside from the 24, we do have 17 patients who do not seek care at Chin Lee Hospital, but live within our service unit. They actually go to other service units, such as Phoenix Indian Medical Center, Gallup Indian Medical Center, the Tsehoto Medical Center in Fort Defiance. We also have 1 patient who just refuses to come in to seek services at all, but is under our radar, and we continue to make contact with this patient. Majority of the patient population that we serve are identified as from the MSM population, men who have sex with men. There's a few who identify as heterosexual or even identify as bisexual. A small number of the patients have indicated that they could have also acquired HIV through intravenous drug use, while majority of the transmission was through unprotected sexual activity that we define as MSM. Some of the challenges that we see working at the Chin Lee Comprehensive Healthcare Facility, the biggest is stigma. We come from a very rural area where our values, our ethics as Navajo people oftentimes align with very conservative values. We're an old culture. We believe in traditional ways of life, and they still thrive within our community. For many years, Indian Health Service has defined Indian health as Western medicine. What Chin Lee has done is, and many Indian health services, is they have bridged the gap and understood from a holistic approach that through the eyes of Navajo, there is no separation between religion, traditional belief, and medicine. That by combining them all, then you approach the patient in a very holistic manner that covers all bases. That is Navajo. And by doing so, we have been able to employ traditional Navajo practitioners who are able to see patients and address traditional Navajo knowledge and work with the providers, the medical providers, exclusively to help this patient. Oftentimes in the community that I'm from, the service unit that I serve, we often have that fear, that hesitation. When you see a booth in the community that says HIV, they tend to walk by and kind of move away from there subtly and not make eye contact with you. It's because we oftentimes have stigma. We oftentimes feel as though, I don't have sex with men. I am a man, but I don't have sex, or I'm married. I don't fit that criteria. I don't think that information is actually for me, but thank you. We oftentimes have to kind of figure out how do we approach those patients. And my best comeback would be, well, you do have grandchildren. You do have children, right? Do you know what they do on these sometimes? Do you know perhaps maybe apps such as Grindr? And do you know what they may be possibly doing when you're not on monitoring them? In today's age, where sexual activity can be just by swiping a bar, oftentimes they're overlooked, especially in our rural communities and among the older generation. Another challenge that we often run into at Chinle is in regards to confidentiality. When I first came on board in 2016, there were 3 patients that came straight to Chinle, and the rest of the 24 were lost to follow-up for years. The reason being is because when you come from a small community, where when you first come into the facility and they ask you, Mr. Curley, how can I help you today? You're asked, what are you here for? And hesitation from the patient to say, well, I may have had exposure to HIV, or I may have had a sexual encounter. I'm here for STI screening. Oftentimes they refrain from saying such things because of our waiting rooms being so open. The other person on the other side of the table who's asking those questions may be auntie, their uncle, maybe their cousin, maybe their good friend that they went to school with. And then from there, they go through the triage. And the nurse that just graduated from UNM is a fellow Navajo who is a good friend of yours, who takes your vitals and asks you again, what are you here for? And then you go to the back and you see your uncle pushing the broom because he's the janitor cleaning. And he says, nephew, why are you here? Then when you're done, the billing department comes and they see your paper and they say, oh, we need to bill for this. We need to put the ICD-10 code in. But that's your cousin because she helps with the billing portion. Do you see all of the different scenarios where confidentiality can be broken? We have a huge addiction rate on Navajo. There's so many different attributions to why we have addiction. Right now, we see a high increase of methamphetamines, which seems to be the choice of drug because of the low cost and the availability. We also see cannabis and ethanol use, and at times opioids. These addictions often make lower a person's inhibitions, what they might actually say when they're in their right mind, they won't say when they're on drugs or alcohol, which make for HIV transmission very high. Living in a rural area, we have challenges of getting to the patients. And one day, when I leave from the office, I go out into the field. I leave from Chinle and I drive to a community called Hard Rock, which is 78 miles. 38 of the miles is dirt road. And during inclement weather, those roads can be very treacherous with mud. And so at those times, when you're driving on those roads, it's a no wonder the patient doesn't present to the facility because they're just not able to. We also have non-emergency medical transports that are able to pick up patients, but even they get stuck on those roads. We live in rural areas where cell phone service is not always an option, that in certain areas, those cell phone services, they won't reach you. And so my job is to go out into the community and say, if John Doe didn't come to his appointment, go out into the community and see what's going on with him. Where is he at? Bring him back to the facility. He needs his CD4 and viral load completed. Aside from all of the challenges that we've run into, I have to bring light to some good that our facility has brought forth. There's always stigma towards Indian Health Service, as any other thing, that we have long wait lines, that we lack confidentiality, that we lack professionalism. But since I came on board, I'm very proud to say that we've worked as a team collectively, the 5 of us, to bring back patients to their home of record, to bring back and to allow them to know that in our facility, their confidentiality, that their dignity, that their respect is our highest priority, and that their health is why we're there. Today, the 23 patients that I serve, I've worked hard to build a good rapport with. I've proven myself as a fellow colleague, as a fellow peer, as a community member, that I'm able to be trusted with information that might not be asked on an everyday basis. I say that because working in HIV, we ask very intimate questions. Sexual practices, the number of people you may have had sex with, those are very intimate questions that are not brought up on an everyday basis, and most certainly not to a conservative population that has very strong beliefs in being respectful. We built a good rapport by understanding cultural sensitivity. We've also made aware of cultural awareness of how to approach a patient, how to sit before them, how not to stare right in their eyes when you make contact with them, but rather, because that's a form of intimidation in Navajo, but rather to come at them at their level and understand their culture. And from there, we're able to make great changes. Stigma is broken every day at our facility, one patient at a time. We try to encourage the patient population now that anybody who has sex is susceptible to HIV, whether you're a male, you're a female, whatever gender or whatever sexuality you define as. We've also hired an STI coordinator who's been able to assist us with what the young lady right before me said in terms of syphilis. We've seen a high number of syphilis cases. In fact, we've had some congenital syphilis within our facility that we were able to catch before birth. We've worked hard. I want to thank you all for giving me the time to come here. You know, I'm not one of the ones in the office to really travel afar. In fact, looking at the men and women in here who are dressed in uniform, it makes me feel as though I'm this small in the equation. The real people that have made good progress are the providers. I'm only one small person in the equation. But you know, the people that I serve from the bottom of my heart, I've told them where I'm coming, where I'm going today, where I'm speaking at, and where the people from Washington were able to hear and to listen to their story of their trials and their tribulations. It humbles us. It humbles us in our heart to sit before you and for you to take the time to listen and to hear what our patients go through. I also want to thank you all for making all the policies that you have done. And Madam Chair, distinguished members of the Presidential Advisory Council on HIV, and all the people who planned this wonderful event. There was a lot of planning that occurred. I thank you all for the opportunity to come here. I know sometimes our patients often feel as though they're left behind or that they're not thought of, but you give them a ray of hope and you give them that ability to see something and to hear something that on a national level, their voices are heard. All of you are advocates, advocates of humanity, advocates of patients and people living with HIV. Thank you so much.
Mr. Curley, your words just really moved me. I'm really emotional. And so thank you. I think what we've all heard, the importance of culture and tradition, of trust, of building relationships. It's so important. It is challenging to hear about stigma, and because when I was doing work in Native communities 20 years ago, and I know it exists across multiple populations, that was and has been an issue. And to know it still exists is it's painful. So anyway, I want to open it up to the other PACHA members to ask questions. Thank you.
I certainly wanted to chime in and be first to express my gratitude and appreciation for this panel. Laura, expertly organized and facilitated by you. But to each one of the speakers, I too am full. And really, I think your words, Mr. Curley, really struck home with all of us. I wanted to say to Jessica that all of you, I just wanted to leap out of my chair every single time each one of you spoke, because you were speaking to the realities that we see in many communities, but it was really acute in terms of my deepening understanding and appreciation for what you're directly experiencing in American Indian communities. So I appreciate your energy and service to bring that forward and bring that to us. Wanted to say to Jessica specifically about, never be embarrassed or ashamed to bring forward what you know are the realities of what you're facing and what your communities are facing. We've been talking about syphilis now for all of the 2 days that we have been convening so far. I can tell you, as I sit in my seat at the Department of Health in Houston, Texas, we announced our syphilis outbreak response on Monday. And that, yes, it is a challenge we see in many communities across the country. So I hope that this resonates and the voice of our experience continues to get lifted in order for us to see a response, an emergency response to clearly what we see are out of control numbers. And then finally, to Rydell, I appreciate also your lifting up the issues around substance use. That's another area that is really a priority for PACHA to look into deeper and address. So I just wanted to express my thanks and gratitude because you really, really resonated. And I'm grateful that you all were helpful to feed us in ways in which we can, I think, turn into some influence and some support for what you need. Thank you.
Thank you, Madam Chair. Next, we have Leo Moore.
Thanks so much. I wanted to echo what Marlene shared. Honestly, I'm just very moved and inspired by what everyone shared today. And specifically to Mr. Curley, you mentioned a few times how you are small, but you're bigger than life, you know, and your impact. It recently, where I work at LA County Department of Public Health, we finally received 4 items for navigators. And for anyone who works for government, it can be hard to get items, right? And so we are just excited to have them. But one thing that I share with our navigators who are nurses is that they really are the glue that connects, you know, our patients to the healthcare center system, to our providers. And, you know, the work that you're doing every day, you are the glue, you know, and so important and critical to the work that we do. So I just wanted to share that and to thank you. I also noted how you mentioned that there is a patient who is not yet ready for treatment, but you are staying in contact with that patient. To me, that is a big part of the work, right? That we maintain that connection so that when that patient is ready, you know, that they know that you're there, you've been there for them, you know, and you're able to help usher them through and get them on treatment and keep them on treatment. So just want to thank you and thank everyone.
Thank you. Are there any other PACHA members who have questions? Oh, sorry, I can't see that far. Who is that?
So I don't have a question, just a comment, and a number of people have shared this, but I just wanted to say, you know, again, that just listening to the panel was phenomenal. I think there were 2 things that stood out for me. One, you know, oftentimes we can get a little removed from the work, and that happens just because of the nature of our roles, and some of it may be just like safety and psychological distancing because we've been doing it for a long time. But I think, Mr. Curley, your articulation of sort of that lived experience of what it really looks like for people on the ground that you serve, I think it reminds all of us of why we've committed our careers to doing this work. And so that's a huge blessing and a huge gift. I want to say also, Heather, that I felt like so I am a nurse practitioner. I work in clinic as well. And I felt like your articulation of Indian Health Service in the clinic, it was so profound, and the realities of what you face, but there was a nuance to it that I heard all these terrific outcomes. And so it was the challenge, the outcome, the challenge, the outcome. And I was really inspired because it showed that despite those structural ways in which Indian Health Service is not receiving adequate space or resources, the number of providers, there were many examples, you're still getting the job done. And for 19 years, you've been doing that. And so just wanted to say thank you to you and all of the people that are doing this work. Thank you.
We have another comment.
Hello. I hear Rydell. Heinzi, the unique linigi in general. Inna beb kan lierigi a owads opahastje. A coho quad nam nishigi a hihat in the deshni. So I just wanted to thank you, Rydell, for your words, and for the work that you do helping, you know, our community. I am too from Chinle, Arizona, so I do understand the work that you do and the facility that you work in. I also wanted to appreciate that the storytelling that you have done in regards to the work that you do did not only touch on the challenges within Native American or indigenous country, but the fact that you made each of your patients, each of your kin, human, rather than a label of American Indian or Alaska Native. And I think that's the most important thing to remember in the work that we do is despite that we are all different in ethnicity and job titles and organizations, at the end of the day, we are all human, and that is the way of Dine. So I want to thank you, Rydell.
Thank you. Another comment?
I just want to take the time to thank the entire panel for this very impactful presentation. I've learned a lot just from listening to each and every one of you. And one of the reasons I'm here is to really understand how we can be more impactful in serving the community. One of the things that I picked up when Mr. Curry was speaking was the integration of Western medicine with religious beliefs and traditional medicine. And I just wanted you to please kindly expatiate a little bit on that, because many times people see these as diametrically opposed, but you've all found a way to bring them all together for the whole person and to serve the community even much more effectively.
Sure. So Chinle IHS was a pioneer in regards to integrating holistic Navajo healing into Indian Health Service. In the early 90s, a gentleman, a medicine person by the name of Johnson Dennison, created the Navajo model. And what he understood was in regards, this was focused on diabetic patients. What they were concerned is that the diabetic patients who we were serving within our service unit were not adherent to medication. They weren't adhering to diet regimens. They were not adhering to exercise. They weren't adhering to orders from the provider. And all this time, what the providers were saying, they ran into these barriers. And so what Mr. Dennison said was, I have a solution. From what you are telling me, with all of these, this is what you need to do, this is the medicine you need to take, you're telling the patient, but from the patient's eyes, the patient's understanding, as a Navajo, there is no separation from traditional healing and Western medicine. If you were to bring the two together and bridge them together and approach the patient with traditional medicine, ceremony, as well as Western, their adherence level may increase. So they created the Navajo model, which entailed, belief system, coming at a patient with cultural sensitivity, cultural awareness, and they hired traditional Navajo practitioners to work alongside with the providers. And what they found was that the patient was more adherent to the medications that they were prescribed. They were more adherent to feeling better about themselves. They felt more energetic. They watched their diet. And from then on, it spawned and it broke into all of the departments within the hospital. And today, our facility, as well as all other Navajo Indian Health area hospitals, as well as 638s, have incorporated the Navajo wellness model for all comorbidities that patients may be facing, whether that's HIV, whether that's, diabetes. That's how it was incorporated. I hope that answered your question.
Yes, thank you very much.
Wow.
Are there any other questions for our panelists? Yes.
I don't have a question, but I just have to say again how amazing this panel has been. And I think that there's such usefulness in how we can take this information and make sure we improve services and resources for American Indian communities. But also these are lessons that I think apply to communities that are heavily impacted by HIV overall. And so thank you guys for that. When I think about engaging, community leaders or like faith-based leaders or in HIV services, I think that's something that really is applicable to communities of color who are impacted by HIV. So these lessons that you're sharing are beautiful for American Indian communities, but I think it's really helpful for all communities of color in the U.S. as we try and respond to HIV.
Thank you. And Justin.
Yeah, just again, another round of deep appreciations for the lived experiences that you've lifted up into the space. I think Radia kind of stole what I wanted to say, which is just, we have the mind meld sometimes. But I do feel like what I've heard in these stories is the exemplar of how you bring culture into our response. And I think that is something that we can leverage and build and understand with other communities of color. So I think you all have really shown the best kind of example of what that looks like. And so I just want to say thank you for that. So I'm just really deeply appreciative for what you brought. And I just think that Brother Corley, you know, again, not to repeat what has been said, but you are not small at all. I mean, I think that what you brought was powerful, it was bold, and it was valuable. And so thank you for that.
And we have Kayla.
I just want to say thank you to all of the panelists, listening to the value that you add to the community that you are serving. Was motivational, inspirational. I also think that it made me realize how much there is like an intersectionality within the different communities and the struggles that we face across all communities, especially Black and Brown communities specifically. And I just want to thank you all because you gave me a deeper insight on what AI, American Native Indians, am I saying it correctly? The challenges that are faced within the community. So I just want to thank you all for educating us.
Great. Any other comments or questions? Oh, one more.
I apologize. My microphone isn't working, so I'm just gonna project.
No, because
Okay. It has this black tape that I thought meant it wasn't working.
it sounds like it's
Oh,
working.
okay.
Oh, is it working?
Is it on? Okay. Thank you. So just two quick comments. I reiterate what everyone said. This was a phenomenal panel. So thank you to everyone. My question is to, I'm going to call you Captain Heather. Thank you so much for your powerful talk. And just two kind of questions. One, you said, you know, you will be the last non-native pharmacist and just the work you're doing in workforce development. So I wondered if you could talk a little bit to kind of even outside of the pharmacist realm, just what that kind of looks like with workforce development for people from the community. And then I also wondered if you could expound a little bit, since your medical center sees so many from the community, about the social determinant of health factors, whether it's housing, employment, education, just kind of the challenges that are faced from that perspective. Thank you.
Yeah, thank you for the question. So, yes, it was always my goal to put myself out of business and to make sure that I trained really strong American Indian Alaska Native pharmacists to come in. And it's been great to see those pharmacists grow. And I've worked with pharmacists at Chinle and Fort Defiance and the Navajo Nation and Anchorage, and I've helped establish some of those programs. And so it really is the work that we do. We have great representation in RNs. Our registered nurses tend to be American Indian Alaska Native. We have a provider that is as well on our team. And it is so important. It makes such a difference if somebody comes in and speaks to them in their native language. And then at PIMC, we have a special challenge because with the over 500 federally recognized tribes, we serve 60% of them. So it's not that we can have one language or one culture. It creates a lot of culture humility, being able to know that there's nuances and differences, and then people practice in different ways as well. And what may be respectful to one person may cause a conflict with another. And so we just have to come in with that cultural humility. And so I think that progress has been really amazing because it is more recent, and I'm hopeful for all of those things. And so I'm grateful that is where we are going. In Phoenix, housing, transportation, substance use, all of those things affect all of our patients. Employment as well. A lot of patients have the choice of leaving their home, leaving their family, leaving their reservation to be able to try to seek a different life, possibly in urban Phoenix, and have a different income or a different life. And it can be a huge decision to stay on the reservation and continue there, being connected to community, but not have the financial support or the type of job or income that they would like. By and large, I think over 80% of our patients qualify for Medicaid. So as an individual, they're making less than $14,000 a year. And so not only are they a marginalized group of incredibly low income, but think of what they do. They take their medication. They trust us. They get their vaccines. They are coming in and showing up and doing the work. And so, yeah, I think that's what keeps me coming back every day, knowing those patients, those words of, I come here because of you. I come here because of you, because of what you said to me the first day I found out I had HIV. And those are the things that keep them coming back. But yes, it is an incredible challenge of all of those things: employment, transportation, housing, and substance use.
Thank you, Heather. I just really, again, want to thank all of our panelists. You are the heart of the work in HIV. And in Indian country, and just thank you so much for all that you do. I so much appreciated all of your words, and it's just been really great to sort of get a glimpse, for all of you to have a glimpse in kind of the work that Maria and I do on a daily basis, working with tribes and tribal people. It's the most beautiful, most rewarding thing like I could do. So I just wanted to, again, just say thank you for this opportunity and for, sort of learning more about our people and issues with HIV and AIDS. Thank you.
Let's give them another round of applause. And I'm so full, I think we can go home now. Our mission is accomplished. No, we have a lot of equally filling conversations left on the agenda. But I did want, before we break for lunch, to offer up an opportunity for some instructions and some guidance from Team PACHA. Caroline, if you can kind of direct us to where we need to go and where we need to be.
Thank you, Marlene. My voice is shaky from the last panel, so thank you. But for folks that are joining us for lunch, we will be in the fresco room. That's if you had pre-ordered the buffet. When you go out this room, you make a left and then a left and go towards the room. Towards the pool. And you'll see the buffet on the left, and then there's a room on the right. And for folks in our audience, we have tons of places around not only the hotel, but there's lots of restaurants around the corner. And we should be back in this room at 1:45. 150. So thank you.
Whoever said 1:45, I'm all for that. Back in the room. All right. See you all after lunch. Thank you.
Produced by the U.S. Department of Health and Human Services.